Welcome to another EduMed video, and in this video we'll be reviewing a new guideline that has come out from NHS England about the use of oxygen therapy during the coronavirus pandemic. Now we'll go through what these new guidelines were, and then I think it's really important to just review the physiology of oxygen delivery and then talk about the implications of the guidelines and things for us to be aware of when implementing these new guidelines. Now, just by way of background, in both Italy, China and in Spain, there have been reports of hospitals being inundated with patients, and with the amount of oxygen that's being needed, them running out of oxygen. What a lot of people don't know is that oxygen is stored near hospitals and it gets topped up every day or a couple of times a day depending upon the oxygen usage, but there's a finite amount of it. So potentially a hospital could run out of oxygen, and there's certainly been a couple of times where hospitals are close to running out of oxygen. In the UK, the British Oxygen Company provide most of the oxygen for hospitals, and they've been doing a fantastic job of keeping up with the higher demands of oxygen, especially with patients on advanced oxygen therapies such as high-flow nasal cannulae, high flows of oxygen via face masks, and of course with intubation ventilation. Now, in general, the saturation target had been, up until now, 94 to 98% for most patients in hospital. However, what NHS England have suggested is that we drop that target to 92 to 94% in the first instance. And this is for all COVID and non-COVID patients, so for everyone. And there's actually quite good evidence that giving too much oxygen for patients can be harmful. Now, something that came out not that long ago was the evidence that actually giving too much oxygen during myocardial infarctions was really bad, whereas the mantra used to be, certainly in medical school, to give patients high flow oxygen whenever patients presented with chest pain. Now, normal saturations is what we are targeting. And the same is probably true of a lot of other things as well. In addition to the high oxidative stress, looking microscopically at the lungs, that higher fractional concentrations of oxygen certainly do lead to micro and macroscopic damage to lungs, possibly through high oxidative stress in those tissues. And that's really what they've said here in the guidelines as well, that hypoxia can be harmful and that lower target oxygen saturations are probably a good thing. And the interesting thing is they have said that we can target sats of even lower, 90 to 94%, if we're running out of oxygen or if the oxygen demands are very high. Now, for those of us in intensive care, we've known for a long time that actually aiming for slightly lower saturations isn't always a bad thing, and rather than giving them very high fraction inspired concentrations of oxygen, we do sometimes revise our oxygen saturation targets depending upon the patient and, most crucially, looking at evidence of oxygen delivery to tissues and seeing whether we're getting adequate oxygen delivery, using surrogate markers such as mixed venous saturations and looking at lactate production, which is a surrogate for anaerobic respiration. Now, it's worth thinking a little bit about what oxygen content is in blood, because that's really what we care about, is the amount of oxygen dissolved in the blood being taken around to the different tissues and then given to the tissues themselves. And you can think of the oxygen content in blood as being formed of two parts. The first is the amount that's bound to haemoglobin, the main carrying molecule in our blood for oxygen. And then also the amount of oxygen that's dissolved in the blood. And by the blood, what we mean is the actual plasma itself. And there's quite a standard equation that's really worth knowing, because it gives you an idea of how important saturations are. So A question that's sometimes asked of me in intensive care is, should I aim for a SATS or should I aim for a PO2? And hopefully by looking at this, you'll get a better idea of which is the most important of the two values to look at. So let's take the amount of oxygen bound to haemoglobin. This can be worked out quite simply. So you have to use a constant, and the constant is the so-called Haffners constant, and you can see it here, which is 1.34. And what that denotes is 1.34 mils of oxygen for every gram of haemoglobin. So if you multiply this by your haemoglobin level, you can then see how much oxygen you can carry in the blood bound to haemoglobin. So you can automatically see how it's really important to have a normal to high amount of haemoglobin in order to improve your oxygen carrying capacity. Now, not all of the haemoglobin is going to be bound to oxygen. And so to work out the amount of bound haemoglobin to oxygen, you look at the saturations. So saturations is given as a percentage. You multiply it by 0.01 to get it into a fraction. And so by calculating this, you will work out how much oxygen is bound to the haemoglobin. Then you can also consider the amount of oxygen that's dissolved in the plasma itself, and that's this bit here. Now, again, as a constant, we know that roughly 0.0225, or we round it up to 0.023 mils, is dissolved in 100 mils of plasma for every one increment in the partial pressure of oxygen. So by multiplying the partial pressure of oxygen by 0.023, you get an idea of how much is dissolved in the plasma. So let's take an example with some typical values. So let's take a haemoglobin of 150 grams per litre. We have to convert that to per 100 mils, and in doing so, what you get is 15 grams per 100 mils. Now, let's take saturations of 100% and a typical PO2 of 13 kilopascals. And let's put those values into the equation. And if you do, you've got 1.34, which is Haffner's constant, multiplied by the haemoglobin concentration in grams per 100 mils, multiplied by the saturations, and we multiply that by 0.01 to get the saturations value from percentage into a fraction. So if you do that, you get 20.1 mils of oxygen per dissolved in the haemoglobin in 100 mils of blood. And then, if you look at the amount of oxygen that's dissolved in plasma, that's the 0.023 multiplied by the partial pressure of oxygen, which you said was 13, you get only 0.299 mils of oxygen in 100 mils of blood. So when you add the two together, the total amount of oxygen that is carried in 100 mils of blood is 20.399 mils. So when you're asked the question, which do you care about more? Is it the saturations or the PO2? It should start to become quite obvious which one's the most important. So the amount bound in haemoglobin is 20 mils, and the amount dissolved in plasma is 0.299. So about 98.8% of the oxygen that is in blood is bound to haemoglobin. And so if you think back to that equation, the thing that matters more in terms of oxygen carrying to tissues is the saturations of the haemoglobin and the amount of haemoglobin. So when you're setting targets, have a little think about what you're actually doing. And as a matter of course, people often set PO2 targets and saturation targets. But actually, the one that you really care about is more the saturations, because the saturations are what's going to then provide enough oxygen to the different tissues in the body. So as long as you've got an adequate amount of haemoglobin and an adequate saturation of that haemoglobin, the PO2 doesn't matter so much. I hope that's clear. Now, the other concept that's really important to think about is the oxygen dissociation curve. Now, because of the protein structure of the haemoglobin molecule, the more oxygen that gets bound to it, the easier it is for more oxygen to bind onto the haemoglobin, and consequently, the easier it is for it to give it up. Now, this becomes important when you're near the extremes of the saturation, so either very deoxygenated blood or very oxygenated blood. And what you get here is a very standard curve, which I'm sure a lot of you have seen. So let's work through it. So here you can see the oxygen saturations of the haemoglobin. So this is what you would measure by putting a SATS probe on the patient's finger. This is the content of oxygen in the whole blood and as a totality. And the reason this line is here is because this particular graph also shows the amount of oxygen dissolved in plasma. So just by eyeballing, what you're immediately starting to see is this is the total amount of oxygen, and virtually all of it is bound to haemoglobin. Only a tiny, tiny amount is bound to plasma. So it's the first thing to know about. The second thing that's really important to bear in mind is that this is not a straight line. What we have is a curve. Where we normally sit is up here. We have saturations of 100%. Compare that to 90%. The total amount of oxygen that's contained in the blood hasn't really dropped very much. There's still a huge amount of oxygen in the blood. So even though you're down at 90%, you're still going to be getting a lot of oxygen. And so this is really the concept behind the targets that they've been talking about. By dropping down to 92%, we're not actually compromising the oxygen content within the blood too much. So on the face of it, you might think that's absolutely great. But what you have to look at here is the shoulder. And this is what we worry about. So let's take a schematic diagram. Again, saturations of the haemoglobin, and this is the partial pressure of oxygen. You can see here at 100% versus 95.8, so 96%, it's pretty much the same amount of oxygen. However, can you see how it's starting to precipitously drop when you get to 92%? Now, still, we're at a decent amount of oxygen, but here, very quickly we get into the steep part of the curve where even just a small change in the partial pressure of oxygen, which is in the lungs, being transferred into the blood, even just a tiny drop will cause a massive drop in saturations and therefore a massive drop in the patient's oxygen content of the blood and therefore the carrying of that oxygen to tissues. So I hope you're starting to see that the safety buffer that's afforded by having a patient at 100% and then you drop down, say, 5%, you're still going to have a huge amount of oxygen being carried. Compared to if you go from 92% down to 90%, you suddenly drop down a huge amount of the oxygen content within the blood. So the real warning that I want to give people when using these slightly lower oxygen targets is be careful. You may have much less of a buffer, and so you might see that the patient, as they start to deteriorate, very rapidly drop their saturations when you're at this shoulder area of the dissociation curve. And intuitively, you've probably seen that. You've probably seen patients that are sitting at SATs of 90-95%, absolutely happy, and then if you, for any reason, cause them to stop breathing, for example, suddenly they can go from 90 to 80 to 70, 60 very quickly, and the reason is that they're dropping down this dissociation curve. So with this additional target, be careful is the key thing. Now you might turn around and say, well, Okay, but why is it okay for us to have the SATS targets of 88 to 92% in COPD patients because we're worried about CO2 retention? Well, it's very complicated, and I'm just going to give you a very simplified answer here. This is not the whole story. But just to give you an idea of why the physiology is slightly different, consider the blue line. This is the normal patient. Now, as you increase your carbon dioxide, you get something called a Bohr effect, a shift of the dissociation curve towards the right side. And by doing so, can you see how this steep line is starting to flatten out? And by flattening out, that drop becomes less precipitous, and so therefore, going from 88 downwards isn't going to cause as big a drop in the oxygen content in the blood. That's the first thing. The second thing is the body is acclimatized to a slightly hypoxic environment, and also the haemoglobin itself has slightly changed its structure with changes in enzymes such as 2,3-DPG and so on. So that's why we sometimes aim for those lower saturation targets with COPD, but we find they don't get that same precipitous drop. Now, in COVID, the honest answer is I don't know how much acclimatization has already happened in these patients. So it might be that we don't see the same sort of precipitous drop but at the 90-92% level and then going further down. And that's because if you look at my videos on the histology of patients with COVID who have had incidental biopsies of lungs for other reasons, who had active COVID but asymptomatic, we see that this inflammatory response, this damage to the lung, this alveolar infiltration has already started to happen. So it might be why patients are the so-called happy hypoxic, sitting there with SATs of 60-70% and being able to speak quite easily with you. And so the body may have acclimatized, so you might not see as precipitous a drop, or patients just might be able to tolerate those hypoxic conditions a bit better. I don't know. But it's certainly important to just bear in mind that you may potentially be on the shoulder of the dissociation curve, so any further deterioration can drop quite quickly. And if these patients are on wards or in areas that aren't highly monitored, you could potentially miss a deterioration until they become very, very sick. So it's just something to keep in mind when using these slightly lower targets for oxygen saturations. So in summary, totally understand the reasons for using the lower oxygen SATs targets. By doing so, we're going to reduce the amount of oxygen demand that we have in the system, and therefore we can look after more patients with ventilatory support. Also, we do need to bear in mind that the higher the fractional inspired oxygen concentration, the more oxidative stress we're putting on the lungs and also on other tissues, and therefore potentially causing damage to patients. But just be careful. You've got a lower oxygen content, but at that high saturations above 90 probably hasn't changed much, but you don't have that safety buffer. You drop down the SATs even a little bit more, you're going to start getting onto the precipitous drop part of the oxygen dissociation curve, and as such patients can deteriorate quite quickly. And in a less monitored area such as wards, you've just got to be that much more vigilant of these patients. I hope you found that video useful, and if you're interested, I'll start to do some more physiology type lectures to go through oxygen content, oxygen delivery, oxygen consumption and so on. But for the meantime, I'll just produce these videos just to give a little bit of a physiological background to the clinical situation.